Bismillahirrahmanirrahim. My name is Dr. Amber Arshad, and today my topic of presentation is Health System Financing in Pakistan and Sehat Sahulat program under supervision of Professor Dr. Sairafzal. In this presentation, I shall be explaining a brief introduction to what is health financing, what are the basic models for health system financing, components of health system financing, financing agents, modes of financing in Pakistan, what are the challenges we are facing nowadays, health financing of universal health coverage, recent advances, and MCQs at the end. At the end of the presentation, the participants will be able to describe the health financing modes and challenges being faced by Pakistan and how health financing contributes to universal health coverage. Now, a brief introduction to health system financing. Actually, health financing refers to the function of the health systems that is concerned with mobilization, accumulation, allocation of money to cover the health needs of the people, either individually or collectively in the health system. These are the latest figures from the World Health or with reference to World Health Organization, which shows that half of the world's population do not have access to the healthcare they need. Over 930 million people spend at least 10% of their household income on healthcare. And 75% national health policy strategies and plans are aimed to move towards the universal health coverage. And around about 100 million people are driven into poverty each year through out of pocket spending. A brief description of the models that are used in the healthcare system based on financing. So, for the global healthcare, there are four major models, and how they work. There are four models: are the Beveridge model, the Bismarck model, the National Health Insurance model, and out-of-pocket model. I shall be explaining a little about these models. So the Beveridge model is mainly financed by the selected government, and it is funded by taxes. And there is no out-of-pocket fee for the patient or any cost sharing. And everyone who is tax paying is guaranteed to have same access to the care at the healthcare sector as compared to other people. And potential risk, there are some risks with this model, and one of this is overutilization. Overutilization of the services that would rise the cost, and higher taxes had to be paid by the people. So this is the drawback of this model. Second model is the Bismarck model. This model is a model that is based on an insurance model, and usually it is financed by the employers and the employees that are responsible for funding by their payroll deductions. But one of the drawback is that it doesn't provide universal health coverage. It requires employment for health insurance. Like for aging population, there is an imbalance between retirees and employees, because employment is must to fit in this model. Third is the national health insurance model, which blends both aspects of Beveridge and Bismarck model. And the government acts as a single payer for the medical procedures, and providers are private. Universal insurance, that doesn't mean that profit, means that it is a universal insurance, and the potential for law, but there is some disadvantage with this system, that is it's insurance based, and the potential for long waiting list and delays in the treatment might affect the people's availability for availing the services at the health sectors. The out-of-pocket model is the most common model, mostly in the less developed areas where there is more rural population. Patients must pay for their procedures out of pocket, and the reality is that that wealthy gets professional medical care and poor doesn't, unless they show somehow have enough money to pay for it. This model of healthcare is driven by the income. These are the three basic components for health system financing. What is the one is the revenue collection, that is used to raise the sufficient funds. Second is the fund pooling, pooling of the money to provide financial risk protection for the population. And third is the purchasing, so that there is efficient resource utilization, and it is done by buying best services with the utilization of funds. Now, with reference to Pakistan, how the health system works, what are the sources, what are the agents, and how the health system financing is in Pakistan shall be explained in the next slides. Financing sources. In Pakistan, there are two main financing sources. One are the public sources and second are the private sources. Through the National Health Account, which is the framework of estimating the total healthcare expenditures at the national level. So the public sources are through general tax, local tax, earmark taxes, and social insurances. However, the private sources include the private health insurances, employee health insurances, and community self-help and philanthropic grants. Now, the main financing agents are actually the agents are the institutions and the entities that channel the funds provided by the financing resources. In Pakistan, the main financing agents are the Ministry of Health, the Ministry of Population Welfare, Ministry of Defense, Zakat, Pakistan Baitul Mal. Some NGOs are also working, some donor funding is also there, and autonomous bodies like WABDA and PI are also contributing as the financing agents in Pakistan. The main modes of financing used for maintaining the financing in health systems in Pakistan are out-of-pocket payment, tax-based revenues, official donor funds, philanthropic grants, social health insurance, social security, and community co-financing. Now, I shall explain each of these briefly one by one. Now, what is out-of-pocket expenditure? According to WHO, in 2018, the out-of-pocket expenditures as the share of the current health expenditures of Pakistan was 56.2%. And the principal mode for this was health financing. And most of the amount from out-of-pocket expenditures are used for having outpatient medicines and vaccines, and 56.2% population is having out of pocket expenditures. So this is the graph that shows the out of pocket expenditures in Pakistan, and in the map on the left side you can see that Pakistan falls in this dark blue region where there is more than 49.35 percent out of pocket expenditure. Second is mode is the tax-based revenues. This mode is used by the government for the collection of the revenue. But in Pakistan, there is a low tax to GDP ratio. But since 2003-4, it has increased and improved to 12.6% till 2018. And this tax-based systems is heavily reliant on indirect tax systems, like on goods, on grocery items we purchase at the marts, and other goods of daily use. So there is the general tax system is weak, and the contribution from the indirect tax is more. Third is the official donor funds by the assisting agencies like WHO, UNICEF, and foreign aids, and it contributes to total 4 to 6% of the health sector allocations. And since 2016, the donor funding has been minimal, less than 2%. There are also philanthropic grants by the foundation, societies, individuals like individuals, Pakistan Baitul Mal and Zakat. The ratio for this contribution is ranges from 0.3 to 3%, and the Central Zakat Council is there also, that provides Guzara allowance to the people living below poverty line, that is 500 per month. And social assistance is also there, which includes food support programs, vocational trainings, and there is also an initiative Tawana Pakistan. Social insurance is more affordable and equitable mode of health financing. Under social health insurances, several schemes are being run in Pakistan. One is the Wasila Sehat Health Insurance Scheme that was introduced in 2012 and it was tax funded. One was Prime Minister Health Insurance Scheme in 2015 that provides 50,000 per family. Later, in 2016, the Sehat Insaf card was introduced, and there was and the it includes the Sehat Sahulat. SSP stands for the Sehat Sahulat program that prioritize the treatment for the chronic diseases, burns and RTS, and provides 3 lakhs per family, for a family per year. And there is also secondary care, like maternity and other emergencies, under Sehat Sahulat program that provides 60,000 per family per year. Under social security, the social insurances includes employees old age benefits and work welfare funds, and it covers 5% of the total population and 3% of the workforce in formal sectors, and it works by pay and pension scheme. And under this, for social security, a SAS program is being run that provides funds and to the deserving people under pay and pension scheme. There is also private health insurance companies that provide health insurances, but the trend of this type of insurances is less because of because of high cost, and it excludes high risk groups and less awareness regarding these health insurances. And last is the community co-financing, that is cost sharing for the countries who are predominantly rural based. And mainly in Pakistan, community co-financing is being mainly provided under Benazir income support programs, Jubilee insurance life programs, microfinancing. Some NGOs are also working on community levels, and there are also some rural support programs run by the government. So, what are the challenges that are being faced by Pakistan in health financing currently? So, mainly the issues in health sector financing in Pakistan refers to three problems, that is revenue generation, pre-pooling and purchasing. So, in revenue generation, the problem is that less revenue is collected. At national level, the problem is that the tax collection system is insufficient, and innovative methods are required for the tax collection, which are being not frequently used at the national level. Donor funding is also less than 2%, that is less than 2% of the national health expenditures. And also there are problems at the local levels. There is also less revenues collected at district levels because cost sharing method is not efficiently employed. Because of this low revenue generation, there is low spending of revenues on health. And as revealed by the Economic Survey of Pakistan 2020 and 21, the country's health expenditure totaled 1.2% of the gross domestic product in the outgoing fiscal year, against 5% advocated by WHO. And there is also one term that is comes under this heading, that is financing deficit. There is the generating funds to finance the deficit was borrowing from public by sales of bonds and by printing new money. So this is also a new term. A solution is to this problem is to improve taxing. Increase allocation to health as pledged in Pakistan Vision 2025 to 3% of GDP. But it is suggested that it must be up to 5%. And the federal and provincial government must work in collaboration and increase the allocation of health budget to up to 3% as pledged in Vision 2025. Second is the pre-pooling, that is health insurance based mode that is being used for the health financing. So health insurance is started but is not universally covered. The outcomes are that the people had a large share of expenditures from out of pocket, around 70%. And there is also another term, that is catastrophic health expenditure. Actually, this is that any expenditure of medical treatment that can pose as a threat towards a household financial ability to maintain. Actually, it is that the total of household budget, if it is being used more than 40% on health and medicine, then then it is then we use the term that there are catastrophic health expenditures, and it is mostly out of pocket. Solution is to expand the insurance schemes to ensure the universal health coverage. And last is purchasing. It includes the mobilization and utilization of the funds. So there are issues with fund mobilization, underutilization, and payments not linked to the performance. And actually, more expenditure is being done on salaries in secondary and tertiary care of the healthcare workers, is up to 15% for the preventive and the primary healthcare uh, professional, and only it is 15% for the preventive and the primary healthcare. Most of it is going to the salaries for the healthcare workers. So the outcome is that there is insufficient and inequitable use of funds. The solution to this problem is to decentralize. There must be accountability and coordination of stakeholders, and must have strategic planning, plans for purchasing. And government should spend more on health service delivery, preventive programs, capacity building of frontline here workers, and governance is also important. So universal health coverage is the high quality, people centered and integrated interventions, and health financing is important to achieve this health coverage. So universal health coverage means that people have access to the health services they need, when and where they need them, without financial hardships. And the SDGs commit to achieve universal healthcare by 2030. And at least 1 billion more people will need to have access to essential health services in each 5-year period between 2015 to 2030. So this is the three-dimensional model that is mostly used by the countries for moving towards the universal health care. It involves three components: the coverage, access, and the cost. The outer box, and there is an inner box. The inner box shows the current pooled funds in countries, the more developed countries like Japan, Korea, Canada, America. The size of this central pool fund, or the central box, is more, and most of the outer box is filled by this blue box because of the better financing systems, and more funds that are used for healthcare sector. And the accesses have the cost, the service deliveries, and the population that are covered are shown by the dimension of this cube. Now, according to this model, three fundamental questions arise. How to finance health sector for universal healthcare? The answer is that there more money for health means that increase the efficiency of revenue by improving the tax collection system, reprioritize government budgets, and allocate more, as suggested by WHO, up to 5% to the health sector. Development assistance for the health, that is global solidarity, is required. Second is how protect people from financial risk. One answer is that the pre-payment pooling method is one method that is currently used in developed countries, and not more frequently used in less developed countries, in which people pay into the pool when they are healthy, and they can draw these funds when they are sick. Funds in form of tax to pay for health insurances, and access to conditional cash transfers, and the access is through the cash transfers and vouchers for this scheme. The third question arises: how to optimally use the resources? The answer is more health for money. that is provide quality service by increasing efficiency and performance of health systems and eliminate waste by performance based financing. Now, how there is universal health coverage taken in Pakistan. Pakistan is moving towards universal healthcare, but still there are some challenges. So, in Pakistan, to materialize the universal healthcare, the central government and the provincial government of KP has started two social health protection schemes. I shall be explaining them later. And there are beneficiaries for these schemes are the people living below poverty line. And under these schemes, there is a premium for poor households, healthcare services provided by the public and the private hospitals. And limited services to the patients in the tertiary care is also covered under these schemes. And these schemes would cover 49 million people for all secondary health care. Now, the recent initiatives taken by the government to achieve the universal health coverage all over the country are, one is the ASAS program that has two initiatives. One is the Insaf insurance card, and second is the Tahaffuz scheme. The Insaf insurance card is launched in 38 districts. 10 million households have access by the end of 2019, and 60 million individuals to benefit from this. This is the target set by the government. And under the Tahaffuz scheme, there is financial access to healthcare which is provided to the poor, especially in catastrophic health expenditures. For example, in case of non-communicable like chronic diseases or other non-communicable diseases. Now, one of the main programs being run in Pakistan for the attainment of the universal health coverage is the Sehat Sahulat program. Under the Sehat Sahulat program, it is estimated that 2,20,000 families will be registered through their CNIC record. The enrolled families can have access to indoor health services free of cost. And there is a panel of 400 hospitals. Indoor treatment and medicine facilities up to 7,20,000 per each family per year. And there is a transport cost that is 1,000 rupees on discharge, and there is also 10,000 rupees assistance for burial in case of death. And medicines are provided for 5 days at discharge, and one free follow-up visit is also provided. Now, what is the current status for this Sehat Sahulat program? 7 million families in district of Punjab, Azad Jammu Kashmir, Gilgit Baltistan, Islamabad and Tharparkar are currently taking advantage or are using this Sehat Sahulat program and are being uh, um, they are getting the advantage of this scheme. Soon the scheme will be launched in Sindh and Balochistan after the approval. And lately in January, it was proposed that Qawmi Sehat cards to be provided to 100% population of federal government in Islamabad. And this proposition was approved in April 2021. Now there are some recent advances. This article was published in this year 2021, showing the impact of Baitul Mal on the socio-economic conditions of the beneficiaries. For this study, the target population was the families that were affiliated with that were registered in the Pakistan Baitul Mal. The findings of the study showed that most of the population in this enrolled in this study, they agreed that the services have positively impacted on their socio-economic conditions. So it is a good initiative, and the Pakistan Baitul Mal is doing good work in Pakistan. The top three influencing factors in this study includes the difficulty in application process, monthly household incomes, and employment status. These are the three influencing factors, but overall there is an improvement in the socioeconomic conditions. Second paper is that titled Willingness to Pay for the Community-Based Healthcare Insurance Schemes in Developing Countries, a case of Lahore, Pakistan. Actually, this patient refers to the insurance system and the insurance schemes that are not very popular in Pakistan. Hence, awareness level of community regarding the benefits of these insurance programs is a major hindrance. And there is a priority to make a policy to increase this community awareness regarding the benefits of this insurance, community based health insurance, and so there is a willingness to pay increases among the general population. This is also the another paper that shows the factors influencing these community-based health insurance, and the result shows that there are several factors: access to healthcare, and the overall the awareness, and these are the main issues that are found, and patients' satisfaction were found to be correlated with efficiency scores. Now, uh, there is another paper that is that making a COVID budget in a struggling economy. Actually, this paper shows that due to the high debt of GDP ratio and consistently deteriorating fiscal deficits, the government could only increase its expenditures for health and emergencies by a restricted amount. And what happened in this pandemic was that most of these expenditures were financed by reducing the development expenditures, and that had a devastating effect on the economic growth. So cash disbursement programs such as ehsas programs may be effective in a short run, but government needs to increase expenditures to these productive activities and build human capital to create jobs and decrease inequalities. And additionally, there is a need to invest in social sectors such as health and education to reduce social inequalities that have worsened during the pandemic. Now it's time for the MCQs. First MCQ is financial protection is measured by looking at out of pocket payment in relation to which of the following: the private spending on health, household living standards, total spending on health, and total spending on education. As I've already told that whenever we are looking for the financial protection, we look out of pocket payments along with the household living standards. So the answer is B. Mr. Abbas is the head of the household. There are total 5 family members. The total earning of Mr. Abbas is 40,000 per month. Due to several health issues, his health cost exceeds 40% of the household expenditures apart from the subsistence cost. This 40% cost that exceeds is also called out of pocket, catastrophic health expenditure, cost sharing, overutilization.
B.
Yes, it is catastrophic health expenditures. Whenever your household expenditures on health exceeds 40%, then it is known as catastrophic health expenditures. What is the most common cause of out-pocket payment that exceeds a household capacity to pay? Outpatient medicines, dental care, inpatient care, treatment to private facilities.
C. Inpatient care.
The answer is A, outpatient medicines. That is the most common out of pocket cause for the people, and mostly the out of pocket payment is used on medicines and vaccines. During the COVID 19 pandemic crisis, a country XYZ decides to cut down the taxes to add more to the health sectors. This is possible via revenue generation, pre pooling, purchasing, and cost cutting.
A.
Yes, whenever there is a scheme or there is a proposition to cut down the taxes and add more to the health sector, it is through revenue generation. In most countries, developing countries, the highest proportion of the national health expenditures comes from the purchasing, the cost sharings, the underutilizations, and the out of pocket payment.
Out of pocket payment.
Yes, the answer is D. In most developing countries, more than 70% of the health expenditures comes from the out of pocket. A country XYZ plans to improve the facilities available at their hospitals by buying more share of total funding to health sectors. After the increase in the budget to the hospital fails to improve their facilities despite having large number of healthcare workers. What could be the reason for the failure? The overutilization, inequitable distribution of funds, cost sharing, pre-pooling.
B.
Yes, the answer is B, unequitable distribution, because as the scenario shows that there is a large number of healthcare workers, so there is an unequitable distribution in the hospital. That is the reason for the failure. In a country XYZ, as per suggestions of the government, a new policy formulated for the country's health sector financing, which is based on taxing and no out of pocket payment will be paid by the citizens. This is according to which of the following financing model? Any
B.
guesses? Yes, the
C.
answer is B, Bismarck model. Government decides to introduce a new scheme for old age and retired people based on the fundamentals of pay and pension, so they can avail free facilities at the hospital. This comes under which mode of financing? Social health insurance, philanthropic grants, private health insurance, social security.
D.
Yes, it is social security. Whenever an old age population is targeted and pay and pension scheme is used, and it is comes under social security. Under the heading of universal health coverage, the best method for protecting people for financial risk is increasing tax, donor funding, prepayment pooling, and cost sharing.
Donor fund.
Um, uh, in most of the countries, the method for universal health coverage is prepayment pooling being used for the protection of financial risk in people. And last one is, I think, is the easy one. How many people are being pushed into extreme poverty, defined as living in US 1.9 or less per day because they have to pay for healthcare? How much is the proportion for the people according to WHO? I think the answer is C. It is 100 million people currently are being living under poverty line. This is the key. These are the references, and thank you.
Thank you very much, Dr. Amber. It is again a very good presentation, and I am very glad that you have presented it brilliantly. If you please stop the recording so that we can discuss many things that are present in this presentation.